Hello there, this is Jasmina Rotu. I am a registered nurse enrolled in the Breastfeeding Experience Theory course at BCIT. Today I will be doing a short presentation on breastfeeding challenges, mastitis, and Down syndrome. Throughout this presentation, I will be using a clinical decision-making framework to explore the breastfeeding challenges. The framework is intended to facilitate understanding of complex issues, guide decision-making, and allow for critical evaluation. The tool is composed of 5 subsections: knowledge, cues, judgment, decision, and evaluation. The breastfeeding challenges, mastitis, and Down syndrome will be applied to this framework throughout the next slides. Mastitis is a common clinical problem, mostly experienced by lactating women, although it can be seen in other groups as well. Between 3 and 33% of lactating women will experience an episode of mastitis. The World Health Organization defines mastitis as an inflammatory condition of the breast, possibly accompanied by an infection, and usually associated with lactation. Mastitis is most commonly caused by milk stasis. Milk stasis has various causes, including damaged or cracked nipples, exposing the breast to Staphylococcus aureus, irregular feeding, for example when the infant starts to sleep longer during the night, failing to empty only one breast completely before moving on to the other side, poor attachment or suckling by infant, illness in the mother or infant which can prevent mothers from feeding or infants from attaching to the breasts, tight clothing or seat belts that block milk ducts and prevent milk flow, blocked nipple pores or ducts from granular material such as dirt, and maternal stress and fatigue. The following have been identified as predisposing factors to mastitis: age, 21 to 35-year-olds, previous history of mastitis, birth complications, poor nutritional status, lowered maternal defenses, employment outside of the home, and trauma. Down syndrome is a genetic disorder caused by abnormal cell division that results in an extra chromosome 21. This causes lifelong intellectual disability and developmental delays. Down syndrome is the most common genetic chromosomal disorder. Risk factors for Down syndrome include advanced maternal age and a previous child born with Down syndrome. Assessment. Common signs and symptoms of mastitis include enlarged, swollen, painful, and shiny area on affected breast, tenderness and heat to affected area, flu-like symptoms including fever, malaise, and headache. Laboratory investigations and other diagnostic procedures are not routinely required. If mastitis fails to respond to regular antibiotic treatment, further tests may be conducted, such as ultrasounds to see the type of mastitis or if there is development of abscesses. Milk samples may also be gathered to culture and analyze the bacteria. Vital signs and a general head-to-toe physical assessment should also be completed to ensure general maternal health. Typical signs and symptoms seen in children with Down syndrome are low muscle tone, including reduced muscle strength in their tongues and lips, and poor head control. Lethargy is common in babies with Down syndrome in the first few weeks after birth, which can hinder their feeding routine. Babies with Down syndrome may have a protruding tongue that pushes against the nipple, hindering an effective latch. We should also assess the mother and infant as a whole. Initially, one should determine the mother's feeding method of choice and support her in that decision. If breastfeeding is the method of choice, the nurse should thoroughly observe the latch and position of the infant, as well as signs of good milk transfer. The nurse should also ask the mother how often the infant is being fed and for how long. The mother should be given a chance to voice any concerns, and the need for assistance should be assessed. So, what could be happening? The characteristics often seen in a baby with Down syndrome, such as low muscle tone, fatigue, and tongue thrust, make latching and positioning during breastfeeding difficult. Poor latch and position lead to ineffective breastfeeding, sore nipples, and an inefficient milk transfer. Sore and cracked nipples and failure to empty breast milk completely and regularly on each breast are precursors to mastitis. Priorities of care for this mom and baby would include consulting a physician for treatment of mastitis, consulting a lactation consultant for help with breastfeeding techniques, consulting an interdisciplinary team to aid the family with emotional and social support in caring for a newborn with Down syndrome, and linking the family with community supports and resources. The top priorities of care for this mom and baby are to treat the mastitis, provide breastfeeding support and practice, ensure proper milk transfer, infant and mother well-being, and finally, psychological, emotional, and social family well-being. Treatment should include moving the milk to prevent milk stasis by breastfeeding and or hand expression. Mothers should be advised to continue breastfeeding and to begin feeds on the affected breast first and to allow the breast to completely empty before continuing on to the next breast. In mothers who cannot or wish to not breastfeed, milk must continue to be expressed to prevent milk stasis and the development of abscesses. Teach mothers to use cold and hot compresses in between feeds to relieve pain and inflammation and to promote milk letdown prior to feeds. Massaging the breasts before and during breastfeeding can encourage milk extraction from the affected tissue. For pain and fever control in the mother, analgesia, such as non-steroidal anti-inflammatories, are recommended. The physician may also prescribe antibiotic therapy for the mother to treat the infection. The mother should be counseled to reduce her stress and fatigue, as these are often precursors to mastitis. Encourage mothers to rest and eat a nutritious diet. Mothers should be advised to avoid wearing tight clothing or sleeping in inappropriate positions, as this can lead to blocked milk ducts. Encourage women to sleep on their backs or sides and to wear loose clothing. Mothers should be provided with support and education about breastfeeding positions, latch, and proper milk transfer. Breastfeeding techniques for infants with Down syndrome include cross-cradle and football hold to counteract the low muscle tone, to dim the room, remove baby's clothes, lightly stroking baby's body, and placing a cool cloth on baby's abdomen to stimulate infant and to keep baby awake during feeds. To latch baby onto breast with mouth wide open and to softly push baby's chin down during latching to address tongue thrusting. Further education should also be provided on adequate nursing frequency and length of time of feeds, as well as appropriate weight gain and excretion amounts. A baby who is getting enough to eat should have around 6 to 8 wet diapers a day and 3 to 5 bowel movements a day. Outcome and ongoing support. Has the mastitis cleared up or are further treatments required? Is breastfeeding more effective for the dyad? Is breastfeeding less painful and is the integrity of the breast maintained? Is the infant and mother well? Is continued one-to-one support and education required? Are community resources and supports being utilized? Are the mother and infant coping? And lastly, ongoing evaluation and follow-up should be arranged. Thank you for listening to my presentation.